welcome to Conversations in Health and Care Improvement, the podcast dedicated to transforming health and care through quality improvement. I'm Amar, Chief Quality Officer at East London Foundation Trust and National Clinical Director for Improvement at NHS England.
And I'm Pedro Delgado, Vice President at the Institute for Healthcare Improvement, and together we'll explore the latest quality improvement agenda, sharing insights, real-world experiences, and innovative strategies that can help enhance patient care and drive meaningful change within our health and care systems.
Whether you're a quality improvement professional, a leader in your organisation, or someone who's passionate about improving health and health outcomes, this podcast is for you. Join us as we dive deep into the challenges and opportunities we face in delivering the best possible care.
Okay, now let's get started.
Today, we are absolutely delighted to welcome Gabby Mathews and Ben Allen to the show today. I would just like to invite each of you to introduce yourselves to our listeners and say a little bit about yourselves, your background, and your experience in the world of quality improvement. Gabby, do you want to start us off?
Thank you so much, Amar, and it's so great to be here with all of you. I'm Gabrielle. I'm a junior doctor in North London, and I actually just completed my foundation training this week, 2 days ago. My journey to being a doctor and to being in this field came from my personal experiences of the healthcare system at a young age, but still also to this day, that made me really passionate about improving the health services at the time for me and my friends, but more recently just for young people across the UK. And now, as I've continued in my first few years as a doctor, but also at medical school, I've had the privilege of working regionally, but also nationally and internationally, looking at how we both build systems in partnership with predominantly children and young people, but with all the members of our community to design services that work best for them. And now in more of my hospital work, looking at how we support younger trainees through their development. And actually something I'm really passionate about is building this kind, supportive health system where we can encourage them to do the quality improvement work that we speak so passionately about. Because I think unless we're truly supported and engaged with building a better system and improving the system that we're working in, we won't get the outcomes that we're all truly hoping for.
Thanks, Gabby. Ben, tell us a bit about yourself.
Thank you. Yeah, great to be here. So I'm Ben Allen. I'm a GP partner in Sheffield, and I got into quality improvement, organisational development really by accident through becoming a GP partner and feeling a sense of ownership over the practice, realising that we weren't working to our full potential, not knowing how to what was missing. And then doing lots of reading, being very curious, and mostly looking around kind of organizational leadership, team building, and then started to put some of those principles into practice. And it's often around kind of releasing potential and how do we get the organization to do what it means to do really well. And that's been really fascinating for me. So that's been my main journey, I think. And I think I've also then become interested in just solving complex problems, because that was for me at the time a very complex problem. And so I'm interested both in, so I'm a GP partner half the week, the other half of the week I do loads of random work, which is mostly around thinking how do we help people doing the work to do the work better, to think differently, to find good examples of things working well, to share it, to spend a lot of time online, going to conferences, meeting people. And the other side of it is how do we help people designing the work that we're doing to design it in a way that's going to most likely get the best experience for patients and for staff. So that's me.
Fabulous. Thanks, Ben. Thanks, Gabrielle. I suppose one of the areas we wanted to discover with you both and bring your experiences to help us think about is what the future of quality improvement might need to look like. Both of you have experience of applying quality improvement in your clinical roles, bringing all of your experience and insights to the work. I'm curious what you've found so far, your experience to have been about, how well does quality improvement really resonate with people who are busy clinicians or trainees or students? And what would we need to do to really make it feel meaningful for people in the next generations to come in our health and care workforce? I wonder, Gabby, whether you want to start us off with your thoughts about how do we help the next generation really see the opportunity of quality improvement and not for it to feel like something that's very different and distinct and something that has nothing to do with their role as clinicians.
Yeah, thanks, Emma. The line that you said of does the term quality improvement resonate to me is really interesting. And in Ben's introduction, he said that he kind of got into it when he was a GP partner, when he was owning this problem and seeing an organization that he was kind of leading not really going well, or not providing the service that he wanted. And for me, that's kind of the challenge, because quality improvement is included in a lot of our training. So my first 2 years of foundation, I had to do a quality improvement project. What that translates to in reality for most like very, very early career junior doctors, so that's your first 2 years of training, obviously in the UK, is to do an audit. And it's often an audit of something that has to be audited in the department, and a change that's going to happen. Like, things are going to change, or things are already changing, and they want an audit to be done, and they ask the junior doctor to kind of come in and do that audit. And in the end, it tells a narrative of what the problem was and a change has been implemented. But I guess not in the way that we all understand in quality improvement, and not in that sequencing that you'd hope for. So I think a lot of people get introduced to this idea of quality improvement in that way of, here is the problem and I'd like you to explore it, and this is your data set, or these are the patients from the last month, and like tell me what happened to them, and this is what we're going to change. And you don't often get that opportunity to be part of the whole thing of kind of recognizing a problem, seeing the people that can influence it or are impacted by it, and then going through from trialing things to learning from your mistakes to trialing them again. And I can confidently say that the only reason I'm so excited about quality improvement is that really early on I got the opportunity to be involved in bigger changes. So in my 3rd to 4th year of medical school, I worked at Imperial in the COVID vaccine uptake team, which was a huge scale quality improvement project in a really exciting way that meant we worked with our data partners at Imperial Health Partners, who were doing this data analysis. We had an active problem that was changing each week, and we had the opportunity to test things really fast. And obviously, how could you not be excited by seeing the changes and hearing people's stories? But most junior doctors don't get the chance to do that. And where they do, I think people get really enthused and they get really passionate about it because they get that narrative. But I think earlier, and this is an assumption, but I think earlier in your career, you're more motivated by your drive. A lot of people early in their career are like in there to try and change things and improve the care for patients. But quality improvement, I think for many, doesn't connect to that outcome. And I think there's a circle, you come back to it, but it doesn't connect to that outcome. So if we can kind of reconnect people's purpose with the purpose of quality improvement, I think that's where we'll find that enthusiasm.
Amar, can I, as we do this translation in this conversation, we'll interpret things with you, and sometimes we'll get it right, sometimes we may not. But Gabby, I'm hearing at least 2 messages there within a very deeply caring and kind ethos. One, that it's important to introduce quality improvement early on in training, and we should celebrate that. The fact that in England, in the UK, that is happening more and more. And number 2, I think you're making a very open invitation to consider how we design that early introduction. If we make it only about auditing, we may be taking only one of the steps of quality improvement. If we make it about understanding the system, planning for changes, maybe testing some of those changes in the limited time that you have, it may be that will create a deeper sense of what quality improvement is and connect even deeper to the purpose of why people join healthcare. Is that roughly an interpretation of what you just described to us?
Yeah, that's perfect.
Okay, lovely. Ben, we'd love to hear from you based on Amar's question.
I think I found the world of quality improvement a bit intimidating, actually. I think sometimes the science and the technology of it, technological side of it can be a bit intimidating. And I'm going to kind of convey the aspect that I feel like I've really got into, and I hope that it maybe comes across in a way that feels fairly accessible. But I'll answer the question first about the future of quality improvement, because I think this is, I think that in terms of like, how is it going to change? And I think that will kind of be a segue into what I was just about to say. I think that there's been a change in how people view work. I think people were quite happy to go to work, be told what to do. They could work in a dysfunctional organisation that wasn't very effective, and they'd go to work because they're getting paid a wage, and they wouldn't question it too much. This is a big generalisation, and I wonder whether or not we've shifted more to where people they want to feel like they're part of something. They want their lives and their work to be purpose driven, and they won't accept working in an organization that is just doing stupid stuff. And they want to be able to be involved. And so I suspect that the change is going to be a lot around increasing autonomy for people so they can get a sense of ownership. And I think engagement is probably the key word that I would say, is that people won't be done to anymore. So I think that some of the interesting bits around quality improvement can come out of trying to give people at work a sense of we're in this together, that giving them a sense that we want you to be able to make changes. We want to hear from you, and we want you to be able to feel like you're able to make the changes that you see. And it can also start from asking that question of, why are we here? Like, what are we coming to work for? What matters to you? What do you think this organisation is? What's important about our organisation? What do we offer the community? And just having free flowing conversations about that. And then you ask the question, okay, so you maybe distill it down and then say, okay, are we doing this? Are we doing it? Do we know how we're doing it? How could we know if we're doing it? And it might be from there that you start to get a little bit of data around that, because sometimes you can be deluded, or you think you're doing a great job, but actually when you when you start asking patients or looking at the data, maybe we're not actually doing as good as we might want. And then you can start asking the question, okay, so this is where we are now. Where do we want to be, and how are we going to get there? And that goes back to the engagement, because if it's just a leader sat there telling everyone what to do, people aren't going to buy it, and you're not going to get the best idea. So then you go back to the team, and you say, right, okay, so if we're going to improve the care of our housebound patients, what ideas have we got, and then you kind of gather the ideas, and you'd maybe even vote up the ones that people want to do, and then people got a real sense of ownership over that, and you get the best ideas.
I think accessibility of this way of thinking and working is going to be absolutely key, isn't it? Because people are certainly busier than they've probably been before, and for this to really be part of the way we think about our work, it's going to have to make sense in our daily workflow and the language we use and the people we work with. So one of the things I think we do need to think about as a group of improvers is, how do we take some of the technical language that might be barriers for people out of the way we think about quality improvement, and how do we ground it in what people are actually grappling with day to day, the sort of things that are giving them joy and the things that are really causing pain in their day-to-day experience. But what you're describing to me, Ben, is really about leadership, isn't it? It's about grounding people back in purpose. Why are we here? What are we here to do? And then let's think about how we all contribute to that. What gets in the way of that? How would we know if we're achieving it? I mean, that is great. Those are principles of good leadership, aren't they, for teams? And I think we should build onto that with what Gabrielle's just taught us about recognizing what everybody can bring to that. I think back to my own experience, Gabby, as a trainee, and in the 10 years I was training, I don't think I was ever asked once to contribute to how a team might improve. I'm not sure there was ever an opportunity or an invitation in all of the 10 years I was training to contribute. And when I look back on that, I think what a missed opportunity, because every 6 months I was seeing different teams, working in different teams. I would have come with a wealth of ideas that perhaps people working in that team hadn't been exposed to. But then I hadn't even been exposed to the world of improvement. I had to leave clinical work for a period of time to learn about improvement in order to come back with a slightly different view of the world. And that's not something that everyone will have access to either. So I think you're right that part of it is what Ben has described about really connecting back to purpose and having this conversation and the space to really make sure we're all aligned around purpose, and then thinking about how we bring people together and recognizing their contribution to it, how we can all use the work of improvement to help us get better at that. Pedro, what are your thoughts about this?
I'm really keen, and the three of you are making me think about books that I read that weave time. So you go into the future, and then they go into the past, and then they're in the present. And I'm keen to invite you to weave time based on Amar's reflection of his own kind of experience when he was training, and maybe not being invited to voice out some of the ideas that you bring with fresh eyes. So the two time spaces that I'd love for you both to reflect on are the moment you walked into a healthcare setting for the first time. What did it look like? What did it feel like compared to what you thought it would? And then I want you to fast forward 10 years from now and look at yourselves training 10 years from now, as if you were starting all over. What would you like for that system to look like? So for future trainees, what kind of spaces and systems would you like for them to be walking into?
Yeah, so it's funny thinking back, and I relate to Amar as well, in that I didn't even think that anything could be done differently. For the first 10 years, I was maybe just focusing on my own survival, or just accepting that it is what it is, and it's taken a while before you start to, maybe it's the ownership thing, you start to think it doesn't have to be this way. My memory was that it was it felt intimidating, it felt quite scary, it definitely felt quite hierarchical, and it felt like I didn't matter as a medical student, and you only mattered as you went through. And even patients, I wonder whether didn't feel like, I know they were just, in terms of the power dynamics, it felt like they were just stuck in the hospital bed with their gowns, and they weren't allowed to leave unless they signed some form. It was what it would look like in the future. I think the main things, some of the things I've already said, really. I think it's that sense that everyone matters just as much. The medical students, the consultants, the patients, everyone matters just as much as each other, and everyone's ideas matter just as much as each other as well. Because some people have got that clinical experience, but some people have got other experiences, both as a patient, but if you're a medical student, but it might be that you've grown up in another country, or it might be that you used to be a psychologist or used to work in the army. Everyone's got stuff to contribute. Or been a carer, and I think linked to that would be, I think, the psychological safety and the trust of acknowledging that everyone matters, and everyone's got ideas.
What do I want in 10 years' time? I'd use similar words, like a welcoming environment where you feel comfortable, you feel like you trust people. I think for me, it doesn't feel like that change is far away. For me, so in foundation training, you rotate every 4 months. And how I feel on day one of a rotation to how I feel at the end of 4 months, that's the kind of change that I'm imagining seeing in 10 years. From going in where you know everyone, and you know the quiet places to get a drink, and you know what to do if a random person walks past you and asks you a question, you can say, oh yeah, I know how to get there. But I guess that how we can make everyone feel that comfort as soon as they arrive, and that if they ask someone a question as they walk past them, they won't get fobbed off, but they'll kind of get their space and their time, and that people are generous with that. I guess that's what I'd hope for.
There's a commonality around your comments, and obviously some uniqueness, because we're all unique, but the commonality is something around inclusion. So making sure that whatever we do into the future, people feel welcome, their ideas feel as relevant as any other person's ideas. The hierarchies are maybe deleted or there, of course, because they are as virtue of the design of our systems, or inherent to them. But we find a way to make those coming into healthcare and committing their lives to it from very early on, like they matter, and their voices matter, and their ideas matter, and that's hugely important. And with that in mind, I suppose one of the things that's coming to me as you speak is the way that we like to think about the 4 domains of improvement. So understanding variation, and understanding systems, and iterative change, and how we learn, and the 4th one, which is human behavior, and within that the psychology of change. And at the heart of a framework that we at the Institute developed a few years ago, which is one of my favorites, is a phrase that is activating people's agency. It feels like both of you are saying that the potential of those that participate in the healthcare endeavor, both as active patients, I wonder if we at some point in history will change that language, because a patient feels like it's waiting there to be done to, as opposed to actively engaging, but also as professionals. So activating people's agency seems pretty central to your descriptions. And Ben, when we were preparing for this, you shared a beautiful experience around, you framed it around releasing potential in general practice, and in your opening, you kind of alluded to the fact that if we were going to make improvements stick, and these are my words, not yours, we need to make sure that it's integrated into what we do every day, rather than this bolt-on that somebody brings along and feels special with a different technology and language and so on. No, we intuitively improve, but we have some things to make it more systematic. That's my interpretation of what you said, but can you tell us a bit about that, your efforts to release potential in primary care, which, by the way, for listeners all around the world, including in the UK, is the place where most care happens. So it matters hugely to the sustainability and future of our healthcare systems. But Ben, we're keen to hear about this effort to release potential that you've been leading.
Sure, yeah. So going back to the story where I arrived at the practice, and there was a sense that the care wasn't what we wanted it to be. It wasn't as good a place to work as we might want, or a good a place for patients as we might expect or want, but we just had to accept that we just didn't have enough resource. And I think that is true to an extent, but it's also true that every day there was just so many things that were happening that could have been better, and I could see that. And I intuitively tried to fix a few things by making a protocol better or chatting to a colleague, and I just found that I intuitively couldn't solve the problem. I sensed that I was always dealing with the symptoms of the problem, and underneath that was the roots of the dysfunction. And I didn't know how to solve that, so I spent time chatting. I spent half an hour with every person, asking them about what they thought, whether were going well, not going well, any ideas about changing things. But then it was mostly from around reading books. I didn't know how I found these authors, but like Patrick Lencioni was very influential, Nancy Klein, Frederick Laloux, Jim Collins, Kim Scott, Brené Brown. These are the kind of people in IHI, and I started to feel there was a lot of overlap between all these different authors, what they were saying, and I tried to put it into a bit of a framework. And what I found was there was kind of these kind of four areas. So one was just Patrick Lencioni's 5 dysfunctions of a team. So that's the kind of like what I call team dynamics. Then there's the bit around kind of like being an intentional organization. What are we here for? What are our values? Are we doing what we mean to be doing? Are we getting results? Then there was the bit around people, around how do we enable people to be doing their best work? So that kind of starts with recruitment, so getting the right people in. And actually, that's one of the things I spent the most time on quite early on, and I learned a lot about recruitment because as a GP practice, you do all the recruitment. And then once you've got people, you're then thinking, okay, we want to make sure that that everybody at the organization is known, they're understood, what they enjoy, what they don't enjoy, where they want to get to in their career, what's going on in their lives, what they're struggling with. And it's not enough to want that in the organization. You need to make sure there's a mechanism that happens, and that's making sure that the small teams where the team leader is someone who does that very naturally and wants to do it, and people want to be led by. So that's the case of finding out who those people are, making sure that they're leading those teams, and also dealing with challenges where performance is not what it ought to be, making sure you're having proactive conversations, and very rarely that might mean someone leaving the organization, but mostly it's just around just trying to help make sure that people thrive and improve personally. And then the other bits around communication between the kind of triangle of leaders, staff, patients. So how are we making sure that engagement process is happening? And we do it. A lot of that's kind of technology as well. So we have social media, we've got WhatsApps, we've got face-to-face meetings, and it's trying to think through, is all that stuff happening? And so it was really through, and people criticize me for not mentioning patients in this often, because actually what I sensed was the people coming to work are really motivated to look after patients. That's what they come to work for. No one can work in the NHS without, you need to be really motivated around care, because it can be a tough environment to be in. And I sense that what we need to do is, if we could enable the team to function well, the team would do what it means to do, but do it much better. And so it was dealing with all those factors. So just to go back to the Patrick Lencioni, because I think that's one of the key things also from Amy Edmondson as well, is building trust, building psychological safety, and having good debate around challenges. And the reason I kind of pull that one out is it's an example of, it's not intuitive. Like, when I'm coming to work and everyone's saying, oh, I'm really busy, I'm really stressed, I don't have time to see patients properly, I don't get home on time, I'm having conflict with, I don't like the person who works next door to me, I would never have thought, oh yeah, we need to build trust and psychological safety. Like, the wait for patients is too long. Because actually it was building the psychological safety that's what enables all the stuff about what's not working and what we could do differently start to pour out. And so, yeah, so I don't know how that answers the question, but once you start, and we weren't really gathering patient data that much at that time, but the patient survey was ticking along. We weren't aiming to be like the best practice or anything, but in fact, no, there's very few people in the organization even know it's there or care about it. But the data has just completely been incredible. We've gone with the second most improved practice in the country, I think, out of 5,000, on continuity of care. Now, I've not even mentioned continuity of care, but people, the receptionists and the staff, they intuitively know that that's how you get good care. But if the organization is actually thriving, then continuity of care happens. And all the stuff that should happen happens. But it's through dealing with the cultural factors, I think, that's enabled all the good stuff to happen.
It's a fascinating story, Ben. Thanks for sharing, and what an amazing journey that must have been to be part of.
Because it was a really lonely journey, because I was reading these books at home. I didn't know anyone outside my practice. And I just read a book and I was like, oh, this is amazing. This is totally what we need to be doing. And another one. And really early on, there was nothing to show for it. I mean, this journey was like a 5-year journey. The first year or two was talking to staff, thinking, reading books, trying to find resources. And then you start thinking, okay, how are we going to build trust then? I need to negotiate running a meeting, differently, and so these things take time as well.
They do. And I guess what I'm taking away from your story is it would be really tempting for people in positions of power to focus on the problem and to try to solve each problem as it arises, one after the other. But actually what you are helping us learn is actually putting the foundations in place for high performance, creating that culture of continuous improvement that enables the team to do the work they need to do. And then you don't need to worry as a leader about trying to make sure everything is solved, because the team will be on it, given the right conditions and the right processes and the right mechanisms for contributing. I think when I was trying to help this organization think about developing thriving teams in the wake of the pandemic, given how differently teams were working and configured and all the changes that had happened, I drew myself a theory of change which had a couple of key drivers in it. One was about thinking about the essentials, really getting the essentials right. You talked about spending a lot of time on recruitment. That was one area that teams spent a lot of time around. The equipment, the recruitment, the people, making sure we're getting the basics in place. The second big driver was about stopping stupid stuff, like freeing up people's time from things that they didn't need to be doing. The third was around coming back around purpose, because people had moved and were working in different ways, and actually grounding people back in, why are we here? Why am I here? Why are we here as a team? And making sure we're all agreed on our common purpose. And the fourth was around contribution, making sure people felt they could contribute and that there was a mechanism to enable contribution to improvement. Because some of that had been lost in changes in working patterns and styles. And what your story is really reminding me of some of what we were thinking about and working on as teams had shifted in the way that they worked post-pandemic. Pedro, your thoughts? What are your thoughts on what we're taking away from this conversation today?
The takeaways from me are always about hope. I think both for Gabby and Ben, the vehicle into this ambition to be a protagonist of the system, not from a ego perspective, but from a what can I do to make my system better, did not come from necessarily from a structured, imposed academic exercise. It came from a genuine, purpose-driven interest and from a huge degree of curiosity primarily and caring for each other, the people they work with, for the people they serve, and also actually for themselves. Gabby, you as a patient initially, and then as a healthcare professional, and Ben, you as a healthcare professional, kind of feeling the almost the need and urgency to do something, to contribute and to serve. And that to me are in shaping health and care into the future is hugely important. I imagine if we were able to work together to activate each other's agency so that we can reach our own potential in a purpose-driven way with some tools to allow us to be even more systematic about how we do that every day, we could shape a very different NHS, we could shape a very different health and care system. So that's some of my own takeaways, Amar, from what we've heard so far from Gabby and Ben.
I wonder if as we get to the end of this conversation, whether we could just invite you, Gabrielle and Ben, to just leave us with a little glimpse of what your hopes are for the future. What do you hope for in the future of health and care improvement?
I think I really hope we get to, like, us being able to ask any staff member in the NHS about their team and their environment, and then being able to genuinely reflect on that it's an environment that they feel they see improving every day and learning and where they're able to contribute. But I think my hope for quality improvement overall is kind of tied up in my hope for like the society and healthcare, because I think when quality improvement's being done really well and you have that continuous improvement, that is only within a system and a society that has that safety and that trust among its members and citizens. So I think it can feel like a really, really big aim, but I think ultimately that's what we're hoping for, isn't it? A health system that reflects the society that it cares for, and that its staff feel a part of just as much as its patients do.
Thanks, Gabby. Ben, what are you hoping for in the future of this work?
So, well, my hope, because I'm often quite a hopeful person, and my hope comes from the sense that when you ask people in an organisation that's not thriving, to what extent are you working to your potential? To what extent are the people around you working to your potential? And to what extent is your organisation working to its potential? You won't find many people who say that it's full. And the difference between where they're at and where full is, that's where the hope is. And that doesn't actually need a whole lot of extra resource. In fact, it probably even saves resource, to be honest. So my hope is that people take that potential seriously, and that unlocking that is taken seriously, rather than just being about delivering outcomes, the number of patients, the number of appointments you've seen, the number of hip operations, because that's the really difficult thing, is when you are overwhelmed with demand to say, actually, meeting our teams, engaging with our teams, building trust, engaging, supporting, finding great leaders, that matters as much. Then it's so my hope is that people take that seriously, and it's also around leadership as well. I think that we gravitate towards leaders who are charismatic, confident, clinically senior, and actually I think the kind of leaders that we increasingly need are compassionate. They're good at listening. They're good at engaging, and there may be people who don't necessarily think of themselves as leaders. And I think we need to find who those people are and encourage them, support them, and redefine what the kind of leaders that we need are. And I think the more we do that, I think we'll create organisations that are great places to work and where great care happens more.
What a wonderful way to finish. Thank you, Gabby, Ben, for sharing your personal stories and your insights and wisdom with us and with our listeners and viewers. Thanks everyone for listening in and joining us for this episode of Conversations in Health and Care Improvement. I'm sure you're taking away some really valuable insights, particularly around the need for us to focus on the foundations within our team to be able to grapple with problems. So thinking about trust and autonomy and contribution as being real key enablers for tackling the sorts of challenges that are forever going to be thrown our way in healthcare.
And building on that, I want to remind the listeners from today's episode that quality improvement is a journey, not a destination, and we encourage you to take the ideas shared here today by Ben and Gabby and explore how they can fit into the unique context of your own system, your own organization, your own team.
And if you enjoyed this episode, feel free to subscribe, rate and review us on your favourite podcast platform, and your feedback always helps us reach more and more people with the insights from our guests.
And remember, let's keep striving for excellence in health and care. We'll see you on the next episode.